everybody. Happy Mother's Day to all the mothers. So this Q&A is it's going to be about knee arthritis because it's something that we see a lot of people having and enduring, and the discomforts of it in the knee. It gets all swollen. Some people don't even realize what their knee looks like or what's causing it. They just know their doctor said it's arthritis, and they look that up and it's inflammation of the bone. And then sometimes they look a little bit more, and AI is really good because it'll tell you what it is. Whenever you just look it up and you're looking for images and stuff, and then you'll need an explanation. But I'm here to tell you from another source what it is as well. We're going to be using the Complete Anatomy app. And if you're a student, it's like $30 a year. If you want to try it out, for anybody, it's free for a week. And if you're a professional, it could be $99 a year. That's what I paid for. Or like $200 a year. So I'm just going to share my app, my screen, and then I'll let you know what it is. We're going to go over. Okay. So it's this app right here. They always change the logo and the model because they're always adding stuff to it. Over time, since I've used it for like 5 years. It's a great app. You forget you have it until you're in pain, and then by that time you've already passed a year, and you have to buy it again for the year. So we'll go ahead and look at the models, and we're just gonna look. Right now we're looking at the male, since it's mother. Oh yeah, we're looking at the female. You're right. It's a female. Okay, so we're gonna go into what can cause this knee arthritis. And right here, we see that we have the hyaline cartilage end plate. That's the hyaline cartilage. And you can see it's on the femoral condyles right here. This little shows you the whole bone. But this area is the lateral one. The fibula is right there. Here's our patella. And then here's our medial one. Knee is designed not to be bone on bone. It does have that cushion, but there's actually menisci between it. And they're like little circle donuts. One's a C shape, one's an O shape. And we'll just look at that real quick. I'll just go ahead and touch off of that bone right there. And let's add, let me move this share screen thing out of the way. Some connective tissue. We'll start seeing. Those are the ligaments. We're looking at the back of the knee. So this is going to be your PCL, and this is your ACL. A lot of sports injuries happen there. If you have knee arthritis later in life, it's probably because you injured your knee playing sports earlier in life, but it can also be from trauma, other trauma. Those are contact sports too. Or it could just be not a contact sport, but you're doing a lot of shuffling on the ground. They call it plant and twist types of motion, side to side. So your knee, whenever you are in extension, it's like a mop the way that it turns. It actually has a rotation with the tibia in those little condyles right there. And we can see the menisces are right here. That is the medial one. And if you have a sports injury, the triple triad, they call it, that one is going to be, I'm going to turn this around. Here's this medial meniscus. And then the ACL. Oh, actually, this is the, what's that? No, that's the posterior cruciate. This is the ACL right here. So it goes, they crisscross the ACL and then the PCL, but the PCL at the back, we're at the back of the knee. This right here, the ACL, let's look at it. Just keeping it highlighted. It goes right here close to the meniscus. Now, if you do tear your ACL, it's most likely from side to side shuffling because you can see how it's crossing, and it just keeps preventing the knee, the femur from falling off of the tibia when you're going side to side, as well as all the muscle groups. Now, this is still the hyaline cartilage right there. This is the menisci. It's actually attached to, so we can actually, so this is the condyle of the femur, hyaline cartilage. I'm going to go ahead and remove this one just so we can look at it, but we'll still have that one. We're going to hide it. And that's the patella without its attachments. It doesn't have its patella ligament on the bottom, which other people rupture. So the meniscus is kind of like an ear shape on the medial one. And then you have this ACL right here, the meniscus. And then you also have, if we add another one, you're going to have the medial cruciate, the medial collateral ligament. Let's add another layer. And it's not showing in that one, but that's the synovial membrane. This is like, you have to keep moving because the synovial membrane, it's in the joint capsule and it has all the fibroblasts. See, your bone when you doesn't have a rich vascular supply to the cartilaginous places. So it has to get it from the synovial fluid. And what it needs is, it needs fibroblasts to build it. And then those enzymes that transport those fibroblast cells into the tissue. People get protein-rich injections, protein-rich plasma, PRP, I think it is, injections, or plasma-rich protein injections, or protein-rich plasma injections. So it's basically your white blood cells that they take the stem cells in there that they make the fibroblasts. And then they inject it in there, and basically all those enzymes that are creating the cartilage, they now have like superhuman ability to do it because they don't have to wait for movement of the knee, because immobile, not moving makes things stiff because you don't get movement. The synovial fluid needs to move around. Movement does that, so that it can fill in those spaces. So let's get back to where we were. I'm going to hide this. We still don't see that medial collateral ligament yet. It should be around here. 10 medial collateral. Yeah, MCL. Yeah, let's see. This is the joint capsule. This is also where they have fibroblast material too, to make fibroblasts, to make the fibrous cartilage type 1, type 2. Hyaline, I believe, is type 1. Menisci, labral. This fibrous layer is type 2. Okay. So the nucleus pulposa is type 1. Type 2 is the disc material, like these menisci, the intervertebral discs, that annulus fibrosus of the disc in the vertebral discs, as well as the labrum, I believe, and the hyaline cartilage. So it's just different variations of it. Type 3, I believe, is the clotting factors that go into repairing wounds in the skin. And type 4 is, I think it's the so type 3, I think, is the fibroblasts or fibrin, something like that. And then type 4 is the actual like clotting factors. Okay. So let's add another layer of connective tissue. Let's see, is that the attachment? No, that's a bursa. That's under a tendon. So oblique popliteal. So there's so many layers of connective tissue. Now we got our deep fascia, our fascia lata, popliteal fascia. These actually, if you actually get an injury and you get swelling these fascia cavities, they can actually cut off tissue supply and lead to necrosis of the leg. So you have to get surgery right away. They call them like anterior posterior syndromes of the leg. All right, so it's okay. So apparently I think it added it with, I believe that was it right here, but let's hide this. No, that's the oblique popliteal one. Let's hide that. Tibial. So tibial or medial collateral. That's what we're looking at. So this and the ACL as well as the medial meniscus or the triple triad that get injured in plant and twist side to side motions. Now we're here to talk about what we can do for people that have arthritis. So let's say, so what happens over time, all that scar tissue, let's say they got it cleaned out, those incisions, they cause scarring, which leads to less space for the fibroblasts, synovial fluid, and everything to move, less range of motion as well. Let's go ahead and start removing these layers. We're just comparing one knee to the other. And that was the bursa for the gastrocnemius. Okay, so let's leave this right here. Now we have, the quads do not really cross the knee because they're in the front and they're still attached to this right here. Okay, whenever that share screen is right there, it won't let me activate any. Okay, so that's the bursa under the knee because the knee's supposed to move with the leg when you twist it. And so there is one head and it attaches to the Gerdy's tubercle right by the fibula where the T-band attaches. Now this is where the patella tendon attaches to anchor the knee down. And then under here, you're going to have the quadratus tendon that attaches to the patella. And the quad's attached to it. You got your intermediate quad, your vastus lateralis, obliquus, and your lateral head of the quad. But those don't actually attach to the knee. I mean, to the actual, they don't cross the knee joint is what it is. And so in arthritis, because of aging, not moving, these start to die off. They start to get worn down. They're not getting replaced. It's just grinding it down, just like you hear about teeth grinders grinding down their teeth. And then that's it. So these are worn out. And then that knee starts rotating on it. And in that center, on both sides, you see how the head of the fibula, let's see if we can unhide stuff. Oh, okay. Yeah, we have to keep on doing it. But how the femur, how it's shaped like this, and then it moves in there. And then it starts to contact those spaces. And there is still some vasculature. There's a vasculature, neurovascular structures that go in there. And then that inflammation from the pain, because it's breaking down, it's eroding. It leads to acidic environment that erodes the fallen tissue. So then you end up losing it, and then gravity pushes down on you. And then you're not working out because you can't, because it hurts. You don't want to move that much. So what happens is your hamstrings, which attach right here, they cross the knee joint. That's the bursa under. They don't actually attach there, but that's lubricating the gastroc. This is the lateral head that attaches. This is the medial head. And then we also have, or actually that could be for the gastrocnemius as well. Hold on. That is okay. So the biceps femoris, actually it's right here that it attaches, the hamstring, the lateral head. And then this one is for the gastrocnemius. The gastrocnemius of the calf crosses the knee joint. That's the lateral head of the top. Imagine the hamstring so tight, not working out, not stretching. And then it's just, you got your knee here, you got your hamstring pulling it up on this side, pulling it up on that side. And then you got your gastroc behind it, pulling it down because it's tight, it's not moving. Just squishing the knee together, plus your weight with gravity also pressing down on it. Now, how can we alleviate this problem? Well, when you have shortened muscles, you need to stretch them, but you also need to strengthen the other muscles too. So depending on how their quads are probably pretty loose too, because they're not using them as much. They're not walking uphill. They're refusing to walk. They're probably going to have really tight lateral calf muscles are peroneus longus and the anterior tibialis from all the foot eversion and dorsiflexion from catching themselves when they're going downhill because it hurts. So we would stretch the lateral, the peroneus longus, peroneus brevis, the anterior tibialis. We would stretch the calf with the gastrocnemius attachments right there behind the femoral tibias, epicondyles, femoral epicondyles. And then we would stretch the lateral head of the hamstring going up across as it attaches to this ischial tuberosity. Well, that's the fascia. But this ischial tuberosity of the ilium. And then we would also stretch the medial semitendinosus, semimembranosus. Those are the medial heads of the gastrocnemius. But you also have, and this is the bursa that they go over. That's not actually where they attach, but it's a bursa. So the gastroc are attaching higher up, and the hamstrings are attaching lower down. But they do attach to the tibia. You would have to stretch both heads of the hamstring, both heads of the gastrocnemius. There's also the soleus too, but those don't cross the knee joint. And when you stretch those, you're going to stretch this Achilles down here, Achilles tendon right here that they all attach to the gastric and the soleus, but not the hamstring, of course. And that's going to help with the tight calves that are pulling on it. So it's going to help take some pressure off from the bottom on the knee, and then also the pressure off the top on the hamstrings. Now let's just add the muscle layers. So we're getting into the adductors. Those stabilize the hip. And so we can see, okay, yeah, so that is the sartorius, no, the gracilis, the sargent, yeah. So the sargent right here, it is where this attachment right here on the knee. This is the area that they call the semitendinosus, membranosus, and the gracilis attached. So that also needs to be stretched because it passes the knee joint, the gracilis. Stretch out these adductors as well. Get in there, stretch it out. And then let's add some more. We're still waiting in here. The gastrocnemius. So we see that we're starting to see our hamstrings right in here. The hamstring tendons, this right here. That is the biceps femoris. That's the lateral head of the hamstring. Okay. And then this person's got really the semimembranosus. Hold on. Hey, be quiet. Detroit, stop it. Be quiet. So we'll add another layer, and then here's more of our biceps femoris. You can see it attaching to the ischial. So this other head, there is parts of the hamstring that attach from linea asperas of the femur. Hold on, in the back of the femur. Get it out. Out. Go. Get. Go. Out. Get out. Get out. Go. Get out. Out. Get out. Get out, darling. Hold out. Go. Out. Yeah. Out. Go. Out. Get out. So we were talking about this biceps femoris. They have attachments on the ischial tuberosity and the femur. Oh my god, you need to get out now. Get out. Get out. Get out. Go. Get out. Do it. I won't at least the loud one out. Jeez. Oh, I love them. They're cute. All right, let's see. So then this is a semitendinosus, semimembranous. Those are the medial heads. See how far that tendon is in the middle. You got your sciatic nerve too that goes underneath these muscles right here, supplying down, splits right here in an adductor canal, adductor hiatus, and then it forms the common fibular nerve as it goes down there, and then the tibial nerve down there. Let's go ahead and add more muscle layers. And then we have right here, this is the plantaris muscle that also attaches to the Achilles tendon. Not everyone has that. And sometimes in surgeries, I think they used to take this one actually out if they had it in other articular surgeries, like the shoulder surgeries and stuff. They would use that tendon. And now we have our gastrocnemius. You can see it crossing the knee joint in the back. So we stretch out these gastrocnemius and stretch out these hamstring muscles right here. You're going to have to stretch both heads. Don't just do one straight leg raise because of the positioning of people's bodies. Make sure you really get in there and pay attention and ask them where they're feeling that stretch. Over time, you can really stretch that out pretty good. Proprioceptive neuromuscular facilitation. It's an active and a resisted to get more stretch. If you get more stretch here, it's going to loosen up pressure on the joint in the back, as well as stretch out the gastroc, loosen up pressure from the bottom also on the joint. And then you can strengthen these quads. Get them to start doing some strengthening workouts with the quads. Also, mobilizations for the knee whenever you have them on when they're face down. Let's see if I can. So it doesn't, that's right, we went over this before. It doesn't allow you to put them face down or up really. It's just like this, unless you want to go like that and then look from the inferior or the superior view, but you can't like turn them to the side. It's just going to rotate it. Yeah. So anyways, if they're on their stomach or if they're standing even. Oh, I guess, is this the male? This is the, I thought it was a female. Okay, so you would just, have them on their stomach right here, which is prone. And then you would bend their knee 90 degrees, like here. And then you would just hold down their hamstring and pull up lightly. 3 sets of 5, help mobilize, take that pressure off the knee joint from the attachment sites of the femoral condyles onto the tibial condyles. And then that would help with knee arthritic pain and discomfort. You can stop that pain inflammation cycle of inflammation, pain, remove the inflammation, get rid of the pain. Keep doing this. They're going to have to do it for a while. Mini treatments. They have to be continuous about their own routine at home as well. Wear shoes that are thick-soled. Avoid going downhill if possible so they can at least start walking. And then if they can, find someone who can give them protein-rich plasma injections in the knee. And if they really need to, they probably will have to get a knee surgery. But make sure they also check out their surgeons and get good advice from other people. And someone I knew did that, but some people are just going to have pain. And that's terrible when they do have to deal with it. But let's with that. So massage, stretching. We can do stretching is in the proprioceptive neuromuscular facilitation. Do some mobilizations with the knee. Stretch out the hamstrings, both heads. Stretch out the gastroc, both heads. And then strengthen the quads. Okay. That's going to help take pressure off that knee and wear the thick shoes. All right. So that's it for this little session. I'm going to go ahead and stop sharing and then stay tuned for the next one. I call this one Underground Healing with Massage Therapy Q&A, because you can facilitate healing in your own body if you knew what to do. Sometimes people need to see what's going on and understand it from multiple sources so that they can activate their own healing process. All right, you guys have a great Mother's Day. See you next time.